All right, we are here with Dr. Ryan Miyamoto today. He is a board certified orthopedic surgeon at Town Center Orthopedics. He specializes in athletic injuries, especially reconstructive surgery of shoulder, knee, and hip. He's originally from Maryland, went to University of Maryland School of Medicine. He did his fellowship at the Steadman Hawkins Clinic, which is a very prestigious clinic out in Vail, Colorado. Works with a lot of professional athletes, Olympic skiers, Olympic snowboard teams. He's been named multiple times as a top doctor in the Washingtonian and Northern Virginia magazine. And he's also currently serving as the chair of orthopedics at Inova Fair Oaks Hospital. So Ryan, thank you so much for joining us.
Great. No, thanks, Jesse. I appreciate you taking the time here. Love to talk ACLs and all things sports medicine. So I appreciate the opportunity here.
Yeah, I'm excited to dive into ACL today. We get a lot of questions from our clients as far as surgery type, rehab. So excited to dive into all of that. So the question I always like to start with, since we're physical therapists that love to get people back to exercise, if you could only do one form of exercise for the rest of your life, what would it be?
Yeah, I think for me, probably something along the HIIT training type programs. I think for me, I was never particularly an endurance type guy. I mean, I think there's certainly some merit in that. I think my mind seems too busy and I can't stay focused long enough. Whereas the HIIT training, I think you get some of the endurance type stuff, but you also get the high intensity stuff. And I think for me, whatever pheromones and hormones that releases along with adrenaline, I think that's the type of exercise I enjoy the best. And I think that's obviously become a trend a lot in the sports world as well. Amongst other things, it seems to be more and more of this high intensity training. So I found that to be kind of my outlet and something that I enjoy. It keeps my mind busy enough. So that would be my one thing, I think, the HIIT type activities.
Yeah, I mean, the constant switching of movements also works for me. So just like, all right, let's keep moving. Let's do something different. And like you said, there's just HIIT studios and HIIT gyms popping up all over the place. So it is definitely a trend right now.
Yeah, and I think it's here to stay. I mean, as far as I know, it seems like they just keep, like you said, get more and more popular and more and popping up. So I don't see that trend changing anytime soon, which keeps guys like myself and yourself busy for, a long time.
So let's dive into. So we're going to talk a little bit about ACL today, but just in general, who's the type of person that you like to help the most?
Yeah, I think for me, as being a former athlete, and as once an athlete, always an athlete, but I think those who are certainly interested in getting back to kind of that form, it's always hard to give up, right? As you age, whether you're in your teenage years, your 20s, your 30s, your 40s, kind of giving up that ability to exercise and exercise aggressively and feel like you haven't lost a step. And so my favorite patient in general is those intense, and everyone's got certain levels of intense athletes. They get injured, they're dying, and will do absolutely anything to get back. And I think for me, those are some of the most gratifying patients to work with because they are really very goal oriented, one track mind. How do we get back and how can I help them along the way? And that doesn't necessarily mean just the super ultra competitive ones, but even those that this is their one outlet in life, or this is the one thing that really kind of makes them happy. So I think that for me is kind of the ideal patient, one who is willing to do anything they can to get back to whatever they like doing from an athletic standpoint.
I was actually going to say, I'm glad you said that because I think a lot of times people think they're in their 30s, they're in their 40s. They're like, I'm not an athlete. I can't get back to what I want to do. Maybe they just want to get back to a HIIT gym or sprinting or anything like that, or recreational soccer. And I love that you said that, like, you can be in your 40s and still get back to wherever you want to get back to.
Yeah.
So what's the latest in ACL surgery in the past few years? I'll start very broad and we can kind of jump into anything you bring up.
Yeah, sure. I think amongst other things, so, the discussion always comes down to things like graft choice. And we've had large multi-trial studies that have looked at, is it better for this graft or that graft or this graft? And so I think some of the data that's come out, at least over the last few years, is that quadricep tendon, autograft quadricep, is now starting to kind of make its mark again. It had been used in the past. It had kind of fallen out of favor a little bit to hamstring, and obviously bone, patella tendon, bone has always been kind of the gold standard, if you will. But we've seen a big comeback in quadricep autograft, and I think particularly the data has shown, as more and more being done, that seems to hold up just as well, if not better, than some of the other graft choices. So I think that's certainly one thing we're seeing a lot more of. The second kind of newer topic, even over about the last 2 to 3 years, although it's been in development for a while, is some of these implants that we use for ACL repair. So as opposed to reconstructing the ACL, as you know, the blood supply typically was thought to be very poor and didn't heal on its own, hence the reason for reconstruction as opposed to repair. Well, there's at least one implant out now. The one I use intermittently is called the BEAR implant, which is essentially kind of a bovine-derived, cow-derived matrix that in conjunction with an ACL repair. So as opposed to having to harvest, say, your own quadricep, your own hamstring, your own patella tendon, saving your own tissue, using your own ACL. And there's very specific instances where I think it's appropriate. Many times it's not. But then augmenting an ACL repair with the second implant that essentially lives just adjacent and forms almost like a clot, but with some scaffolding associated with it that we use with the patient's autologous blood. That's really been shown, at least over the last couple of years as the data gets better and better to hold up very well in terms of return to sport. I think in terms of morbidity, in terms of as quadricep weakness, altered gait mechanics, I would argue that I've seen, at least anecdotally, less of that than we typically see with other autograft sources. So that's become, I think, a big thing in ACL repair as opposed to reconstruction. And then the other thing we're seeing a lot more of is now, I think, the indications for a secondary procedure, namely a lateral extra-articular tenodesis, LET, or the other secondary procedure, an anterolateral ligament reconstruction. So not only reconstructing or repairing the ACL, providing a second source of stabilization, particularly in revision type cases, particularly in you have those patients that are hyperlax, kind of whether they're EDS or just even isolated at the knee, they seem to go into hyperextension. But that's now, I think, become more of a common procedure in conjunction with, again, the standard ACL reconstructions.
Interesting. So one thing you mentioned a few times, if somebody's listening, in the simplest of terms, what's the difference between a reconstruction and a repair?
Absolutely, yeah. So the classic teaching, which is not wrong, is that the ACL, because it's intra-articular, so it's in the middle of the knee joint, the blood supply isn't as robust as, say, the MCL, which lives obviously adjacent to the joint, but just on the outside, which is why most of our players and athletes who have an MCL injury, frequently they're treated non-operatively because the blood supply is so robust, whereas the ACL, because it doesn't have nearly the same blood supply, is either reconstructed, meaning we say, okay, we take out the remnant stump, if you will, of the native ACL, take a graft, whether it's from their own tissue, aka an autograft, or a cadaver, an allograft, and use that to essentially recreate a new ligament. Now, there's obviously some morbidity that comes with that because you're now harvesting an athlete's own tissue to make a new ligament. And so there's some donor site morbidity. We obviously try to minimize that, and that's very much a part of the rehab, which you folks do on your end, versus, say, an ACL repair where we say, okay, we're going to keep the native tissue. And again, that's why it's in a fairly small percentage of ACL tears that we can actually do this. But if there's enough tissue to work with, we can actually keep their own tissue, repair it, meaning we actually stick it back onto the appropriate origin point off of the femur. And then ACL repair in and of itself, the data didn't look fantastic, but we now not just repair it, but then augment it. Meaning we also put in a specialized implant that ends up being kind of coated in the patient's own blood in terms of healing factors. That's been shown to actually have very good success, and not just at time equals 0, but even at return to play timelines, 8-9 months, and showing to hold up long term, which I think is the most exciting part for us. It's almost a blend of, the mechanics of classic ACL, combining that with now these new biologics, PRP stem cells. It's in that category, but it seems to do well and at the cost of less morbidity versus, again, taking someone's own hamstring, their own quadricep, their own patella tendon.
Got it. And again, just if somebody's listening, morbidity would mean like weakness or tightness, or like if I get a hamstring graft, or let's say a quadricep graft, there's typically a lot of quadriceps weakness afterwards. So that bare procedure can kind of limit that residual quad weakness afterwards.
Exactly, especially in the early part of therapy. As you know, you've seen time and time again, particularly in the early part, is the quad's weak and the gait's off. Well, with the bear, because you're not harvesting any other tissue, their quadricep is not particularly weak. Whereas with a quad autograft, if we dive into that later, I mean, it's a great procedure, provides a great ligament for us. It's nice and thick and holds well. It's very stiff. But there's obviously a little bit of downside of taking tissue elsewhere. There's kind of paying the piper, so to speak. Whereas this implant, in the appropriate cases, it's not for everybody, but in certain tear types, it can be a nice alternative that at least so far is borne out to have pretty good results. It's starting to become more widespread. We're seeing, I believe it's the NFLPA, don't quote me on that, but I think they put a significant sum of money into looking at that. Obviously, they have players all the time with ACL tears and kind of minimize the morbidity when those injuries occur.
Got it. Okay. So we talked about bear, we talked about quadricep, we talked about the LET, you mentioned a hamstring, you mentioned cadaver. There's so many options when someone is considering surgery. So if someone's considering ACL surgery, how should they decide what kind of graft to get? I'm sure if they go to 3 surgeons, they might get 2.5 different recommendations. So what would you say? How should someone make that decision?
Sure. No, I think it's an excellent question. And certainly a lot of the visits we get in the office are discussing that. Just me personally, I do every different type of ACL graft for different reasons. And so for me, kind of the pathway I use, I think if it's a young, say, collision sport athlete, I think for me, the 2 grafts that hold up the best in the sense that they give a nice, thick, solid graft are either a bone patella tendon bone or a quadricep autograft. So taking essentially the middle third of the patella tendon with the small bone block from the kneecap and a small bone back from the tibia, or taking the patients on the top of the kneecap, taking a sliver of about a 10 millimeter by 65 millimeters of quad. I think both of those give a nice, beefy, healthy graft. Some of the re-tear rates in the data we've seen come from grafts that are smaller than, say, 8 or 7.5 millimeters in diameter. So for me, when you harvest someone's hamstring per se, and it's not the wrong procedure, but I found that the size varies. So you might have a guy that's 6'5" that's got tiny little hamstrings, and a 5'2" female that's got thick hamstrings. And I think once you take the hamstrings, there's a couple things we can do to make it thicker intraoperatively. But even then, the quad and the patella, in my mind, are much more consistent in terms of graft size, and therefore, in my mind, help to decrease re-tear rates. Now, that being said, it's not for everybody. And the patients that I'm not as convinced those are great grafts for, or if it's someone who either has difficulty rehab or already has some maybe significant anterior knee pain. So this is not the 19, 20-year-old, collegiate soccer player, but say, an active 45-year-old who's already got some significant patella wear, but still does some kind of, aggressive sporting type activities or skis or snowboards. Those are one where I'm certainly less likely, say, to use a patella tendon graft. Or if they have a history of, say, jumper's knee or chronic patella tendonitis, I'm less likely to use that graft. There, I think quadricep and or potentially hamstring's an option. And then there's others who we've talked about who have said, look, it was kind of a freak accident. I like to jog. I like to bike. And we've had discussion even about allograft in certain instances. If there's a reason why, hey, I'm not really looking to add any more morbidity to the knee. I didn't recover well. I never recovered well, from my other knee, et cetera. It's at least in the discussion. I tend, again, personally to save that for patients 40, 45 and up. Not that it's bad, but I would argue the re-tear rates are probably a little bit higher. So if you've got someone who's got a high exposure, again, think collegiate basketball, collegiate football, field hockey, lacrosse, who's out there 3, 4, 5 times a week, I think the exposure rate is a lot higher. And so for those patients, for me, I don't love to use allograft. But that's kind of the general consensus. But it is certainly patient specific, no question about it. I think the hard part as a patient, as you asked, is how do you know which one's better? I think it's a detailed talk with the surgeon about, hey, what do you expect in terms of morbidity? How much is this going to set me back? What's the long-term re-tear rate? Re-injury rate look like? I would love to tell you it's 0%. Unfortunately, it's, as you know, it's not 0%. But it's an involved question. Obviously, the surgeon has to be comfortable with it. You have to be comfortable with the surgeon, first of all. But I think it's worth a discussion. Like I said, we talk about it all the time in the office in terms of it tailored specifically patient by patient.
Yeah, and I think a kind of a hidden piece of what you just talked about, and just on a personal note, I've known Ryan for years, and I make every single person that's considering surgery go see him. And I say you can't see anybody else until you see him. Purely for what you just said, I think that discussion is so important, right? You're not saying this is what has to happen. You're taking into account their preference. You're taking into account their lifestyle, and you're having an actual discussion back and forth. And I think whether you see Ryan, whether you see another surgeon, just make sure you're seeing a surgeon that is actually talking to you and having a discussion with you rather than saying this is what the plan is and not having your input at all. So I think that was the hidden piece of what you just talked about right there.
I appreciate it. Yeah. And we say the same thing as they go off to therapy and rehab is I think discussing goals with your therapist. Hey, here's where I want to be. What does it look like? Have you seen other patients? Have you rehabbed other patients with this specific goal? And I think that's the patient more than anybody's got to be comfortable with the process, starting from diagnosis to surgery to rehab to getting back. I mean, it's a little bit of trust, but you have to have that good rapport. You have to kind of know who you're going to battle with, so to speak, and make sure you're confident in the team. It's much more than just the surgeon. It's much more than just the therapist. There's a lot more than that has to happen for a successful outcome.
Yeah, I couldn't agree more. I think that question is so important. And I don't think physical therapists, I don't think doctors, I don't think healthcare providers ask that question enough of what are your goals and when do you want to get there and how do you want to get there and make it a two-way discussion. So I love that you ask, what are your goals? So we talked a lot about surgery. We get this question all the time. Let's say you said active 45-year-old wants to get back to some sort of activity. Can people have an ACL tear and not need surgery?
They can. And I think that's also the other question that comes up. Excellent question is if I'm ACL deficient, can I still do XYZ? Now, I would tell them in general, there's always a risk, right? So kind of just the big picture risk is that, certainly the data would suggest that there's a little bit higher risk of arthritis down the road. Now, that being said, 45 and I'm 47, so this is relevant to me, not that I have an ACL tear, versus say a 19-year-old. A 19-year-old, we're fairly persistent, or that age group, hey, look, your risk of getting arthritis early at a young age is a lot higher if you go ACL deficient. But that being said, say 45, 47, it doesn't mandate surgery. And I think if, the athletes, let's talk sports specific, if it's, say, a competitive swimmer, an adult competitive swimmer, if it's a cyclist, I think those are maybe some of the activities where you don't necessarily have to have an intact ACL. Now, again, are there downsides? Could you have intermittent signs of instability? You could, but certainly if you have the right therapist on board, I don't think it mandates that you have to have it done. I think if you say, look, I'm a competitive tennis player, or I still play a lot of aggressive basketball or adult league soccer, there I'd be a little more concerned about that cutting, pivoting, twisting, mostly for the fact that, again, if you shear off a chunk of cartilage, if you kind of get a big nasty meniscal tear because you're constantly exposing yourself to these types of movements, there I'm a little less excited about treating them non-op. But certainly there are patients where we, again, very specific sports that we say, look, we can try, see how it goes. You need a good therapist. And if you do high risk things, say you go skiing a couple times a year, You should probably brace, make sure you're maximizing your quad, your hamstring, things like this. So it's the same thing. It's a discussion to be had based on kind of that patient individually, what they enjoy doing, what's their exposure risk, how frequently are they doing these running, cutting, pivoting sports.
Yeah, I've got somebody right now who MRI confirmed ACL tear, probably chronic. She probably had it for a really long
Mhm.
time, and she's back to CrossFit and doing almost everything in CrossFit, making small modifications around the edges, and choosing to do 90% of things and not do the other 10% of things. But she's doing just great. Now that's not for everybody, like you said, but I do think it's important for people to realize that it's not necessarily a definitely have surgery, definitely don't have surgery. Again, talk with your surgeon, talk with your physical therapist, like get a whole plan around what you're dealing with.
I agree, Jesse. Absolutely. We get that question all the time. And I think that's, again, I don't think people know that as much as you would think that an ACL certainly does not mandate surgery. And I've seen, just like you have, people getting back to sports multiple times again and again without necessarily an intact ACL, or even with a partial, who get back to a lot of things as long as they've maximized some of those surrounding kind of support structures.
Yep. So, you said yourself, really important for surgery, post-op rehab, the whole process. So what's the latest that you're seeing in ACL rehab?
Yeah, so I think one thing that we've seen a little bit more, not that it's brand new, but I think we use BFR a bit more than we used to. I think, when that first came out, again, and I would defer to you even, I may have heard about it more through you or learned more about it from you than myself, but reading about it, I think we've used that technique a little bit more. I think if the patient can tolerate it and you have obviously a therapist who's well versed in it, I think it does actually help with muscle hypertrophy and early recovery. So I know that's one technique that we'll use. Not just say for ACL, Achilles, etc., but I know that some patients tolerate it well, some people don't. In general, what I've seen so far, I think I've been fairly impressed with. I think one of the other things too, with just more of a principle in general, obviously early range of motion, the long arc quad stuff that we used to try to avoid, I feel like that's becoming less of a daunting kind of exercise than it used to be. I think one of the things that we've switched to is realizing, hey, this may be okay. And whether that's the thoughts have changed on it, the data's changed on it, some of our reconstruction techniques are a bit stronger than they used to be in the past, and backups. And a lot of times there's something called an internal brace that helps to kind of further support the ACL. But I know the long arc quad stuff we used to avoid, and keeping in a brace for so long, I think now we're trying to get out of a brace earlier and earlier, particularly in a patient you can trust. I think the ones where I still hesitate are my young, super aggressive teenage male. As soon as you turn your back on them, they're bouncing around. So there's some we almost purposely keep them longer, but those in general are some of the bigger ones we see. I'm presuming, and I know you've been using some of these techniques for a long time now, but that seems to be, I think, a trend. And so far, there certainly hasn't been any compromise in results. And if anything else, I think at least getting patients in that early phase back to being functional and normalizing the gait and navigating their kind of day-to-day routines. I think it's gone well. I don't necessarily let them return to play any sooner. There's always a rush to, hey, we're going to rehab like crazy. We're going to have you back in 5 months or 6 months. I think at least our data again would suggest that the re-tear rate's still a little high, but I think getting a patient back to functional as early as you can, functional, not playing soccer, is still a key part of this. And like I said, I think those are some of the basic things we've seen. And again, I defer to you, may know clearly more than I have about those, but I've been very happy with those techniques so far.
Few things I want to dive into there. So mostly just to remind myself, let's dive into BFR, let's dive into leg extensions, and let's dive into return to sport. So BFR is blood flow restriction, basically involves a big thick cuff that goes around your thigh, which restricts blood flow to the muscle as you're working it. We found the same thing, whether it's post-operatively or people that are in a lot of pain, it's just a great tool to start to build strength. So basically what you're able to do is get fatigue, even if you don't put a ton of stress through the muscle, right? 2 weeks out after surgery, you're not able to put a lot of stress through the knee. You add BFR, blood flow restriction, and all of a sudden your quad feels like you just did 300-pound squats just by doing something simple,
Yeah.
and you're getting a ton of fatigue. So yeah, I would highly, highly recommend anybody who had, whether it's ACL, whether it's hip, whether it's, like you said, Achilles is awesome. Blood flow restriction, I think, is really, really important.
Jesse, have you found that most patients can tolerate that well? Again, you're the one who's hands-on doing this stuff. Do patients
Yes.
typically tolerate that well? That one I don't know the answer to.
No, it's a good question. So what Ryan's saying is the cuff can get pretty tight. So we actually restrict blood flow quite a bit. And so what we find is research shows for lower extremity, we want to restrict blood flow by 80%. And so honestly, almost everybody tolerates it. But if they don't, then we'll just drop it down to 50% or 60%, right? Whatever they can tolerate. And maybe it's not as effective as 80%, but we're still getting some sort of effect. And then usually after a couple sessions, we can bump that pressure up a little bit. Honestly, it's probably been 4 years since I had somebody who just said, no, this is not for me. And then long arc quads. So that's knee extensions. Sitting, old school, sitting on a machine and just extending your knee out. Which I love that you brought that up because I mean, when I started my career 18 years ago, there was so much messaging out there about long arc quads are bad for your knees and knee extensions are bad and it's going to hurt your kneecap. And I think there's still some of that message out there. Just the other day he didn't have an ACL surgery. He just had quad weakness. I asked him to do some knee extensions. He went to his trainer and told him, and his trainer was like, you should never do those ever again. Okay, great. I'm glad you brought that up because research shows it's perfectly safe to do long arc quads and do knee extensions. And I think, while you didn't directly say it, you kind of did. The most important thing after ACL surgery is quad strengthening. That quad getting strong is just the number one thing for return to sport or just return to life. And we see people all the time, 2, 3, 4 years after ACL surgery, they'll come into us and they still have quad weakness because they never got it back.
Yep. Same thing for us. We'll see they come in, they've torn their contralateral side that they're seeing us. And, oh, by the way, doc, I had an ACL surgery, a couple of years ago. And you look at their quad and they're like, wow, I can't believe, you got cleared to go back to sports to tear your other ACL because your other knee still looks like it never recovered. It's amazing. So I'm hoping a lot of that change as some of the data and the science and what's safe and what's not safe continues to progress. I think it's especially with ACL because, as you know, we're just going to see more and more of these injuries.
I think one reason that we see a lot of quad weakness is there was a big push towards functional exercise, functional movements, which I think is great. But just doing squats, just doing lunges, if somebody already has quad weakness, you're going to get the hip to kick in more. You're going to get the glutes to kick in more. And so what we have to do as therapists is really design programs that isolate the quad. And I think what I see too often is people get pushed into functional exercises too soon, or it's not a well-rounded program where functional exercises are great, but we have to isolate the quad. Otherwise, we're going to get the hip to kick in or we're going to get something else to kick in and we don't get that quad stronger. So again, love the long arc quads for that. I don't think there's anything better.
Yep, I agree with you.
And then let's talk about return to sport. Tons of debate around that. People want to get back in 6 months, accelerated rehab. What's the latest in that?
Yeah, I think same thing. So I think the surgeon, the care team, the therapists, et cetera, believe me, everyone's rooting for their, our patients to get back as soon as they can. I think, sometimes you read something here and it's like, oh, this doc can get you back in 6 months. This one's 8 months. This one's 9 months. As you know, Jesse, it's very, very patient specific. And why it is that some people with the same surgery, same surgeon, same therapist, same protocol, their quad and their knee looks great at 6.5 months, and why some it looks at 11 months and it still looks like they're struggling. At that part, I don't have a great answer. I know at least, again, some of the data in our sports journal would suggest a super aggressive return to sport, aka less than 6 months for aggressive cutting sports. Some of the re-tear rates are a little bit higher. And I think, to me, I like to set, as we talked about goals with a patient earlier, like, look, realistically, I always say we should plan on about 8 months, 8 to 9 months. And if things go well, maybe you're a little ahead of that. If you're struggling a little bit, maybe a little after that. So I don't even like to throw out the 6 months because I think it opens up expectations. And so from what we're seeing, I think the earlier than 6 months, unfortunately, has shown a little bit of a higher re-tear rate. And the problem is, right, you go 5.5 months into this and you re-tear. I mean, it's tough to battle back from, not just physically, but obviously from a mental standpoint as well. So for me, I'm still, as we get back to sport, I always like to have the therapist involved, even if the patient has kind of gone on and been, quote, rehabbing on their own. When we start to have that discussion, okay, we're around month 7, month 8, are we really going to start flirting with getting you back to sports here? I always actually adamantly, I have the therapist back involved. I'm running through kind of whichever version of the sport test and looking at their mechanics and lateral bounding and single leg bounding and how's their hip strength, etc. To me, the hard part with this is patients want to know, hey, am I 100% okay to go back? And I always have the talk, look, this is not an exact science, but here's our best data is that, hey, you're not rushing to get past the 6-month mark. We're starting into the time frame where many athletes get back. Let me have you go see a therapist I trust. Let me have them look at your mechanics and see how you do and which sport is it. And certainly for me, I don't return any athlete back without the discussion with the patient. We look at the time frame, we consider their tissue, we look at their leg, we kind of take a long, hard look at what the therapist has said. And then obviously, again, I still like to have them in front of guys like you just to say, hey, look, we don't think there's any reason you should have a problem before we give them the green light. And sometimes that's the hardest part, when they know they're on the doorstep. And it's like, well, we just ran you through a number of different things and it looks like you're still falling into valgus. It looks like you're setting yourself up. And that's part of the conversation as well. But yeah, it's certainly a team approach in terms of getting back to sport. I'm sure you're getting the same pressures on your end, Jesse, from the patients.
I think it's really important what you just said of it's not a blanket time. It's more about where is your knee at rather than it's 6 months, I should be able to do this, or it's 3 months, I should be able to do this. And really making sure that it's individualized to your knee and where is your strength at? Where are your pain levels at? And correct me if I'm wrong, but I think even waiting like from 6 to 9 months to return to sport, is it still true? I haven't seen any of the most recent. Is it still true that the retear rate drops pretty significantly if they wait just that extra 3 months?
Exactly. Yeah, it's much better data. Yeah, in terms of that. So I think that's, and again, there's pressures these days that, as you know, with it's a recruiting season, it's I'm AAU basketball seasons. It's one of those. Believe me, I tell the parents all the time, like, look, my heart feels for your kid. They're a senior in high school, but at the same time, they go through surgery. We let them go back just because for peripheral reasons, and there's a re-injury. It's heartbreaking.
Yep. Yeah. So do not rush back after surgery. Just your retear
Take
rate
home point.
will go way up.
Exactly.
So Ryan, this has been great. So if you wanted to leave people with one message, or if you wish there was like one piece of health advice that everybody knew, what would that be?
Sure. I think amongst other things, at least in terms of injury and ACL specific, I think some of the concepts we talked is when you're going through, it's a process. An ACL injury is a big deal. They're common, but that doesn't make it any less of a big deal. And I think choosing your team wisely, your surgeon, your therapist, having an open discussion about graft choice, an open discussion about rehab timelines, an open discussion about, hey, Jesse, how am I doing in rehab? Am I falling behind? I think having that trust in your team is the most important part going through this, not just for a successful result, but if God forbid there is an issue or you have a re-injury, you at least know, hey, I went to battle with the team and I'm confident in them. And if something happens, these are my guys, this is who I went with. And so I think that's the most critical part. I think sometimes, again, we'll see patients that are like, well, I talked to the doc for 2 minutes and he told me this and I wasn't sure. And my therapist doesn't, for whatever reason, doesn't seem to be following protocol, just seems to be doing whatever they think is right because they've done this 100 times and this is the way they do it every single time. I think those are the things you have to, as a patient, it's hard because you don't know, this is not your field, but you have to take a step back and say, okay, look, do I feel comfortable with this? Do they seem to be engaged? Are they open about how the process is going? I think that's the key piece, whether it's ACL or any other surgery, but certainly with ACL recovery, to make sure you're open conversation with your entire team from A to Z, because it really is a team effort coming back, at least if you want to get to the same level with these types of injuries.
Yeah, I think that's an awesome message and completely unsolicited. Ryan didn't ask me to say this, but again, if you are considering surgery or not surgery in Northern Virginia, Maryland, DC, go see Ryan. Mostly for what he just said. That open discussion is just so important, and everybody who's I've ever sent to you leaves saying that was a good experience, right? Which doesn't always happen with orthopedic surgeon. There's not the best reputation as far as like person to person interaction. So I really appreciate like how much time you spend with people and just have that open discussion.
Sure, and I appreciate it. And I do think what helps, Jesse, is having, and again, Jesse didn't ask me to say this either, but I usually get a heads up from Jesse in terms of the patient coming in, what their situation is, how are they doing in therapy. So again, that communication, I know, okay, this patient's coming in. On paper, it looks like this, but their therapist has told me XYZ coming in. And same thing on the way out is, hey, Jesse, saw her, saw him. Don't think they need surgery. Think they need it. I think, what are your thoughts about this? I think that's the key part. So yes, I appreciate you saying that. And again, I appreciate you on the other end as well, kind of giving us more of a bigger picture as these patients come in to see us.
Yeah, communication between healthcare providers is just so, so important. So, Ryan, this has been amazing. So, if people want to find out more or get in touch with you, where can people find you?
Sure. The easiest way is, so my first name, Ryan, Ryan. Last name is Miyamoto, Miyamoto, MD.com. Ryan Miyamoto, MD.com is an easy place. There's some videos, I think, hopefully very kind of written in layman's terms about ACL reconstruction, about ACL, about bare implant, kind of the newest things. We try to update that fairly frequently. And there's a way to drop us a note and ask us a question, things like that. So I think it's hopefully a great resource for patients who have ACL injuries or recoveries, or do I need surgery? Do I not need surgery? What are my options? A good place to start, even before they come in. I think it makes any office visit that much more productive if you have a little bit of background, especially if you're not in the healthcare field.
Yeah, that's great. Ryan, thank you so much for your time.
Okay. Thanks, Jesse. Appreciate it.